Hello, welcome to a very special episode of It's All Relational. I am Trevor White, the technology chair for WAMFS, and we are joined today by a number of guests that are going to be having a very robust conversation about how insurance works for marriage and family therapists in Washington State. So we are really lucky today to be joined by Commissioner Patty Kuderer. Thank you so much for joining us today, Patty.
Happy to be here. Thank you. And I'm joined by Jane Beyer, who's my senior health policy advisor as well.
Wonderful.
Morning.
Thank you so much, Jane. And then we also have President of WAMF, Billy Tyler, here, and legislative advocate Amber Lewis. Thank you all for being here today. Yeah. So, we are excited to highlight and talk about how the Office of the Insurance Commissioner works and how we as marriage and family therapists can interface best with you. So, Patty, could you give us a better sense, explain it to us as if we had never heard of the Office of Insurance Commissioner, which probably some of our listeners have not. How does this office work with marriage and family therapists in Washington State?
Yeah, thank you, Trevor. So the Office of the Insurance Commissioner, broadly speaking, regulates the insurance industry within the state. Our goal is to protect consumers while making sure that the rates that are charged to consumers are actuarially justified, which is just a very scientific way of saying that they're fair and that they're based on the risk that's being underwritten. And that's what we do with respect to providers. We work with them in terms of making sure that there's network adequacy and within the networks that the health plans cover. That was a law that was passed by the legislature a while ago.
Wonderful. And what drew you to this role in the first place?
Well, I was in the legislature for about a decade, and I decided to seek this job several years ago. I started looking at it seriously because many, many years ago, I had given birth to an extreme premature daughter, and she spent 5 months in the hospital and was critically ill during that time. And there were times when the 5-month stay that she needed care that some bureaucrat sitting behind a desk somewhere said wasn't necessary and was experimental. And so they denied the care. I'm a trial attorney by training. I had done insurance defense as well as having sued insurance companies in the past. So let's just say I was able to short circuit the appeal process of that denial. And while they paid for her, I knew that they were denying care to other tiny infants that were in the NICU at the same time my daughter was. And by the time I brought her home, there was a letter from the company not welcoming my daughter home, but instead telling me that she had nearly reached her lifetime cap. And so that put me on a quest to universal health care. And that actually has been a constant for me for over 30 years now. She's 32 and just graduated law school. So that's why I decided I knew that when I was looking at how do we get there as a state, the staff in the legislature said, this really needs to go through the Office of the Insurance Commissioner. And that's when I decided that that was something I wanted to do.
Wow, what an inspirational reason, a personal reason to start this. I'm very happy to hear that she's doing well and graduating law school. Congratulations on that.
Thank you. Thank you.
Could you tell us a little bit more about how your office supports diverse mental health providers such as MFTs?
Yeah, thanks for that question. And I want to just start generally speaking. We don't have authority over the reimbursement rates, but we do have authority to make sure that mental and behavioral health providers are treated the same as medical surgical providers in how payments are calculated and also in how patients access their services. We have recently created some resources on our website for providers and their patients with, for example, help on how patients can get a next day appointment, how to help patients who've received a denial, as well as information on billing standards and how to resolve disagreements with insurers. So this is something that I've been telling folks around the state already, that if you're having issues, we want to hear from you. We are especially in need of patterns of behavior from insurers. And we think that your organization is especially equipped to help us with that. And that helps with our market conduct and enforcement work. And if there's more that you're looking for, I'm sure Jane can fill in a little bit there too.
Sure. Thank you. That's very helpful. I know you mentioned a little bit towards the resources, but if providers are having trouble with an insurance company, or where should they go if they encounter issues with a payer?
I'd like them to file a complaint with us. We changed the practice before. It was consumers that could actually file complaints that were acted on. And when a provider did, they were doing it on behalf of a patient. But we have decided that it's probably best that we hear directly from providers on issues that they're having as well. That will give us a better look at how the system is functioning overall. And so we want to hear from them, and we will assist in any way that we can, with the understanding that our jurisdiction is limited. We can't set the rates, but we can certainly look at the parity and whether or not they're being treated similarly to the medical surgeon.
Excellent. Thank you. What's the best way to file that complaint? Is there a specific resource they should use, or a website or email?
Well, we have a website, insurance.wa.gov, and it is right on the front page. We have a policy of no wrong door. So it really doesn't matter how someone reaches out to someone at the Office of the Insurance Commissioner. We'll make sure that it gets to the right division within the agency. We're a small but mighty agency, and we really want to make sure that people know that we're there to protect consumers. And so we would encourage you to file a complaint. You can pick up the phone, too. We have a hotline as well. I don't have that number memorized
No,
yet.
that's okay. That's very helpful, just to know that there's so many options, and that, which I love the no wrong door policy, that they can get help or get sent to the right direction if they just reach out, is what I'm hearing is most important. There are many clinicians who face lower reimbursement levels for the same services compared to other providers. How does your office address this disparity?
I'm going to pitch it over to Jane for that.
So, as the commissioner mentioned, this office does not have the authority to say to an insurance company, you're paying a psychologist X, you need to pay an MFP the same amount of money. We just don't have the authority to do that. Our authority relates to enforcement of behavioral health parity. And what we can look at and have looked at in our enforcement actions is, how does a health insurer decide how much they're going to pay a provider? And what needs to be comparable is how they decide that across medical providers and behavioral health providers. So are they looking at the same factors? Do they have a hard and fast limit that they apply to behavioral health that they don't apply to med-surg? And so that's where we're focused. The parity statute, it's called MAPIA. That's the alphabet soup for the federal parity statute, is very complex. Enforcement is complex, and it's one tool in a toolkit. And in some cases, the legislature has directly taken on reimbursement. For example, in Senate Bill 5083 that passed the legislature this session, that capped the rates that could be paid to hospitals for state employee and school employee health plans. A critically important part of that legislation was that primary care providers and outpatient behavioral health services be paid at least 150% of what Medicare would pay for the service. And we strongly advocated for inclusion of that provision in that law because we had done research on how much mental health professional fees were compared to physicians' fees, and they were indeed far lower.
Thank you. Thanks for that work as well and participating in that. What's being done to ensure marriage and family therapists and other mental health professionals are properly acknowledged, like for their credentialing and their different scopes?
Yeah, that is also going to be a Jane question. And I should probably let you know, I mean, I've only been in office for a short while, so I'm getting up to speed on all of this, but Jane really has the answer to that.
Thanks. So this is a really interesting question. We have standards that we call network access standards that health insurers have to meet to let us know that they have enough healthcare providers in their networks to meet the needs of the folks who get coverage from them. And those network access standards will say something like there need to be a sufficient number of outpatient mental health providers. They don't say you need to have X psychologists, X MFTs, X number of licensed clinical social workers, X number of counselors. What the insurance company is responsible for is to make sure that they have a sufficient number of mental health professionals to meet the needs of their clients. We think that that generally does include MFTs, but there are not super rigid standards about each licensure classification that is included. We know that a health insurer can't say, I am categorically excluding MFTs from my network. That's not okay under state law. But the mix of providers that they have in their network is really up to them.
In my past experience, and I hope this relates, in my past experience, I have heard that there are some insurance payers who have excluded specific licenses, like we're full for MFTs or we're full for LMHCs. Is that going against what you just described?
What I would describe would be a health insurer saying, we are not going to contract with any MFTs. That is not okay. But to say, here's how we want to make up our network, and if our network is going to have a balance of psychologists and MFTs and licensed counselors, that's okay. As long as their network can meet the needs of their enrollees.
Okay. So as long as they have enough providers, they can decide the kind of makeup of how many of the different types, as long as overall they have mental health providers. Okay.
Right. I mean, they need to ensure, for example, that they've got enough folks who can serve kids. And so that might dictate to a certain extent what the mix of mental health professionals might be.
Okay. No, thank you. That's helpful. How does your office approach the issue of, I should have practiced this word. Sorry, can we try it again? Is it actuarially?
Actuarial.
Actuarial. I was like, well, if we can take that part out and I'll try again. Okay. Are we ready? Okay. How does your office approach the issue of actuarial soundness in rate setting, and what safeguards exist to ensure fair reimbursement?
Yeah, I mean, in terms of premiums, the rates and insurer requests must be, as you noted, actuarially justified. And what that means is that the rates have to be sufficient to cover the risk that's being underwritten. And when the OIC talks about rates, we're talking about the premiums for health plans. For individual and small employer health plans, insurers have to prove to us that the premium they want to charge is justified. And again, in other words, they need to show us that the claims that they'll have to pay for healthcare services are driving the amount of the premiums that they want to charge. So premium amounts, they're driven by several components. How much the insurer is going to have to pay for healthcare services used by their enrollees is one of them. And that's a combination of the number and type of services used and the price paid for those services. Insurers' administrative costs, which are capped under the Affordable Care Act, those are also included. And also insurers need to have sufficient reserves so that they're able to pay all claims that come in. And that does include very high unexpected claims that may come in. So I think, that's the basic overview of how we look at the premiums and the rates that the insurer requests to be actuarially justified. But there could be other components. Jane may know more, but those are the top ones that I'm aware
of. Those are the top ones. And getting back to the question of the rates that the providers are paid, we are very aware of the dynamic that our healthcare system has gotten very consolidated. We have some very, very big health systems. And then we have folks like MFTs who tend to be smaller independent practices. And we know that there is a lot of bargaining leverage for those big healthcare systems when they go to contract with health insurers, and that there's less leverage for the smaller independent providers. And Amber will remember all of the discussions around a piece of legislation last session, House Bill 1589, that was attempting to try to get at having a bit more balance in that relationship between the health insurers and especially the independent providers. And that bill didn't pass. But I think there is still significant attention because we're also concerned about wanting smaller independent practitioners to be able to sustain their practices and stay in business so that your only choice isn't, well, I can go work for a big hospital system, or I can sell out to private equity, or I can become part of Optum, for example, right? Because Optum owns some medical groups. So we completely understand that dynamic, and we understand the challenge it presents. I don't know whether the MFTs have thought about, are there ways that we can join together that don't violate antitrust law, because nobody wants to violate antitrust law, to be able to negotiate more as sort of a larger group with health insurers. That might be something that you might want to speak to very smart lawyers who understand antitrust law about. So the fact that our authority is limited doesn't mean that we are not fully aware of the issues and the dynamic, which is why we sort of say, well, we can at least try to look at it through a mental health parity lens.
And it sounds like your recommendation for like Washington Association of Marriage and Family Therapy or Marriage and Family Therapists that are primarily, like you're saying, individual providers or private practices, is to, band together more to negotiate as opposed to appeal to your office specifically. Like you're saying, there's limits to what your office is able to do in terms of the actuarial soundness of the rates.
And I think the question there is, organizationally and from a business perspective, what would need to happen in order to be able to band together and do it in a way that was not considered a boycott, right, or collusion that would call into question antitrust concerns.
And we're certainly open to, talking with your organization about what that could look like. But Jane is absolutely right. This does require some legal advice, which we're not able to give. But we are working with other, sectors on how to combat this issue overall of accessibility to insurance. And would be more than happy to be a resource for you as well.
That's excellent to know. I know in my own personal experience, being a private practitioner, where it's just me, I'm the solo practitioner. I mean, there were times that just sitting on the phone trying to get reimbursed was taking like hours, like 5 to 7 hours for one client hour. That actually led to me coming off of insurance panels for that reason. And as we're like talking about coming together, I think it makes sense that if there's more of us, that's a stronger voice. And I worry about, will they even listen? Because I couldn't even just get reimbursed for the work that was already approved. I mean, eventually I got it, but that was a huge eye opener for me that financially I couldn't sustain my business if I was spending that amount of time trying to get reimbursed at a lower rate than the rate I submitted and spending that amount of time. So I just didn't know if you had any thoughts on that.
Well, I think it's a real problem in the healthcare system, and it's something that I know the legislature has been focused on. Prior authorization has been a real big issue as well that we focused on when I was there. And there are definitely ways to improve the healthcare system. We definitely understand the challenges that MFTs face, in addition to other practitioners, quite frankly, with this very issue. And again, we want to be a resource and a partner on that. We want to look for patterns that violate the law. And when it does come to MAPIA, the mental health parity law, we are actively engaged in investigating those issues. And we just recently issued a fine to United and Primera. And I think that, and we're doing more work in that regard as well. So it's the main leverage that we have right now, but we are definitely focused on making sure that, that our people have access to behavioral health. It's so incredibly important. And I think, especially now, more than ever, given the pressures that we're seeing happening around the country, I think that this is really a critical need that we need to make sure people have access to.
And I do think that when you're on the phone, right, first of all, I am so sorry that you've felt the need to just practice outside of insurance, because we want to acknowledge how difficult that decision is to make. And on the one hand, on the other hand, we want insurers to be able to build adequate networks. And so this is why I think what the commissioner said earlier about, if you see one insurance company and you're seeing a pattern or practice that they're sort of imposing across the folks that you're serving, if they're saying, we will not pay for a session of more than X minutes, if they're putting excessive burdens on providers who want to get credentialed to come in. And if you see patterns like that, that's the information that's particularly helpful. to us.
Thank you. Yes, it was a very difficult decision. And even just thinking about wanting to provide an equitable practice, insurance certainly helps to be able to do that. However, I think what I went through is like weighing out being able to just be a provider and be able to be there to provide care for someone versus financially that just not being possible as a single practitioner in private practice. It was the numbers just weren't adding up. So I appreciate that. And I think it's really helpful for other MFTs and just mental health providers in general to know that you want to hear about that, especially if it's coming from one certain company and we're seeing a pattern of that. You also mentioned like the change, like wanting to know about the change in times, like the amount of time. And so many clinicians have seen times reduced from 55 to 45 minutes or less, raising parity concerns. How does your office ensure true parity in mental health care?
Well, I can tell you that the parity laws are complex and enforcement can take time. And in terms of our mental health parity authority, parity looks at the processes and the policies that health insurers use and how they apply them to see whether there is comparable treatment between mental health and medical services. That's it in a nutshell. What parity doesn't mean is that the payment to a therapist must be the same as what a doctor is paid. It looks at how the health insurers determine what the reimbursement rate is, and that's what must be comparable. When we often ask health insurers to give us data on specific reimbursement rates prior authorization decisions, I mentioned that earlier, where we see significant differences between mental health and medical services, we consider that a red flag and we want to investigate further. We'll dig deeper. We'll ask the health insurer how their policies have resulted in such a big difference. And that gives us the opportunity to compare those policies. And we, like I said, we stand behind enforcement of any violations, even when the federal government will fail to do so. You probably know in 2024, the federal government strengthened the enforcement of the 2013 mental health parity regulations. But this administration just a month ago said it wasn't going to apply the stronger enforcement requirements. And Washington State, though, we said that we're going to continue to enforce that 2024 rule that was on the books. That's our prerogative, and we are going to do that, and we have been doing that. We've also been strengthening our behavioral health parity work since 2018. We applied for and received federal funding for that work, and the state legislature gave us additional funding when that grant cycle ended. And because of that work, we've been able to take enforcement action. I mentioned this earlier against 2 insurers so far, United and Premera, and we impose significant fines. And we are still actively involved in that parity compliance work. We know how important it is, and we want to make sure that the insurers are following the law. And lastly, I just want to point out that we've also developed resources to help appeal a denial. And again, it starts with you reaching out to us. And we want to make sure, like I said, that people have access to these services that are so critical. And that does require us to hear from you when you notice that there's a problem. And Jane may have more to add to this. I'm not sure, but that's my take on it.
Right. And the only thing I would add is one of the challenges that we've had internally is I'm not a therapist. I'm a lawyer, and I don't know what's clinically appropriate or not. And in addition to the legislature providing us with funding dedicated to mental health parity enforcement, they also gave us a generous appropriation to seek out clinical consultation. So we are in the process right now of working on a contract to bring some behavioral health expertise to us on a consulting basis. We're also going to bring in pharmaceutical expertise because in addition to individual client issues, we regulate pharmacy benefit managers and we look at how their formularies are structured. And you need a pharmacist to tell us whether the way a formulary is structured is discriminating, for example, with respect to mental health medication. So that's another big change for this organization. To my knowledge, we've not had that kind of clinical expertise available to us. So that gives us the ability to sort of say, okay, this health insurer says that it's not medically necessary to do a 55-minute session. Well, is it necessary to do a 55-minute session if a provider is trying to adhere to clinical guidelines around CBT or DBT therapy? And that's the benefit to us of having access to that kind of clinical expertise.
And I would like to add just one thing to that as well. And we also added a behavioral health attorney in our legal division as well. And I think that that was an important hire. And we're also hiring an AI algorithmic expert, because when we're looking at how those premiums are set, sometimes they have very complicated and complex algorithms, and we need to have that expertise as well. The legislature was very good in terms of appropriating all that funding for us to be able to access this expertise. And I think that that's just going to make us much more skilled at how we go about our job of enforcing mental health parity laws.
And Billy, I think this is like a great transition when we think about the future of MFTs and our legislative strategies, understanding that our members see families in dynamic situations that take time to evolve. Marriage and family therapists are usually more than one individual seeking services of keeping a family intact or helping partners communicate to help raise their children. And one of the challenges that we've heard over and over from the membership is how do we get that acknowledgement that MFTs deliver care in a very dynamic setting with multiple individuals. Sometimes our folks find themselves in an ethical dilemma of having to feel pressured in a diagnosis in order to get the coverage, even though that may not be appropriate. So one of the things we've talked about as a legislative committee is looking at Z codes and trying to get a better definition of the scope of practice of which MFTs deliver care. So maybe talk through what that means from a clinician's perspective and how we can maybe partner with the Office of the Insurance Commissioner to look at a Z code to make sure that when therapists are delivering in a dynamic setting with a family in need or a child who's transitioning and needs extra care, how we can partner to get that acknowledgement.
Yeah. So from a clinical perspective, it does become this ethical dilemma of there are many clinical practices that actually would say that providing a diagnosis to one person in the system actually creates worsens the dynamics, because now the appearance and the feeling for that member is that they're the problem, that we're treating them and everyone else is there to help them. And really for us as true systemic thinkers, it's the dynamic that is the problem, not the individual. And so it's difficult to sometimes function within our current healthcare insurance structure system because it is individual based. Z codes, I think, are a opportunity for us to explore and feel like we can be more equitable. Providing, because I think that's another reason why some MFTs choose to not use insurance, is because it's kind of this dilemma of, do I give a diagnosis that maybe I don't feel is as accurate so that my clients can utilize their insurance benefits, or do I say I can't do that because that's not what is clinically relevant or accurate, and then they can't access their benefits. And so it really puts the clinician in a tough spot. But the Z codes allow, since those are relational diagnoses and talk more to the dynamics, I think those could be a great opportunity for us to maybe explore or partner on.
Yeah, I definitely think that is something you would want to partner with the legislature on for sure, because what you're talking about is you have to put in a code for someone who you don't really want to put a code in for, because it's really not about them. As you said, it's about the dynamic, right? And the legislature has done things like that in the past in terms of mandates for healthcare coverage. And I think that would be something that they could address. Our office can be supportive and assist in providing information and data and that sort of thing, as we have done before with the legislature. But it is a real issue. And I think it probably is an impediment to some people getting help. And that is what we don't want to have. We want to help remove those obstacles and impediments so that people have access to their mental health coverage, their behavioral health coverage. And I don't think I can underscore this point enough, just how important it is. It's mind, body, spirit, right? I mean, it's all together. And we have for so long in this country neglected mental health. It wasn't until the 2000s that we had the Mental Health Parity Act out of the federal government. So I think it's really important that we remove those obstacles when we see them. Honestly, given what I've seen in the legislature, I think you would have a receptive ear there. It's a short session, so, you got to factor that in. I'm sure Amber is quite aware of that. But I do think it's a conversation worth having and certainly exploring with legislators.
I think that makes sense. And I agree. I think it does sound like there's especially a emphasis on children's health and supporting our youth. And from our perspective, youth's best system of support is to strengthen the family dynamics, so they have a stronger support system. And so I know that, again, oftentimes the person who ends up getting the diagnosis is the child. And conceptually, that could just cause challenges, even unconsciously, around how things are structured. So thank you.
Billy, I just want to say I completely agree with you. I think the labeling is a real problem. I know just from, my daughter certainly wasn't fine after 5 months. It took about a decade before she was no longer medically fragile. And during that time, there were lots of labels put on her. And the one that really got under my skin was that she had a learning disability, when it turns out that I realized that LD just stands for learns differently. And I think it's, especially for children, to hear those words, it can be really harmful. And I'd like to see us avoid that as well.
And so many of the clients that are coming through our offices, families, couples, right, they're in these situations where the problem or the dynamic is much more relational. And, kind of like Billy was speaking to, individual providers then have to make decisions about, how do we move forward here? And I guess I'm curious about that with working with your office within the existing laws and regulations. How can we best advocate for our clients when they're working with insurance companies and dealing with denials?
Well, I would say for sure you need to let us know when there's an issue. Because like I said, I'd like to be a partner. I want to be the first call that patients and providers make when they have an issue with their insurer. That would be number one. I also think that identifying those patterns that we talked about is really important. So that gives us the ability to enter into a market conduct investigation and to see what we uncover there. And if we do uncover violations of the mental health parity law, as I've said, we will enforce that. We believe very strongly in the mental health parity law and in having folks have access to mental health services. So we'll do what we can on our end to help with that. But it's a partnership, and so we need your help as well. We need your help to help us do our job in terms of reporting the information that we need to know.
And in addition, let's remember that consumers have appeal rights, and I know that they're bulky, and I know that being able to pursue a successful appeal often means your provider backing you up and writing that letter, that medical necessity letter. We actually added onto our website a great template for a medical necessity letter that your members can use, sort of like, what are the high points that I need to hit? And then where there's an opportunity to request a peer-to-peer discussion, if it's an issue, if it's a prior authorization issue or a concurrent review issue, being on what we have heard is that being on the phone with the clinician at the insurance company can be a lot more effective than just emails back and forth or whatever you're putting in through the claim submission system. And being able to say to patients, pursue that appeal and just keep it going so that ultimately, if you prevail, the insurance company, especially if it's somebody who's continued in therapy because they need it, to just keep that option open so that ultimately the insurance company could end up paying for those claims. So it's both.
Yeah. And as you were just sharing about that, I think that's excellent to kind of know what the different avenues as a provider and also how to help support our clients in their advocacy for themselves. One thing that came up for me, though, is that oftentimes our clients are seeing us in a time of distress where they might be struggling in some of their symptoms themselves, lack of motivation, fatigue, irritability, all of these things could make it a lot more challenging for them to persist when there's a lot of obstacles. Sometimes it's hard just to get out of bed, and that's why they're coming and reaching out. And that was a huge accomplishment, just to like pick up the phone and call us. And so I think that's what came to mind when I was thinking that, is like, in theory, that sounds really like a good idea, but then just trying to like encourage a client who's already struggling just to do their basic day to day to then continue to persist in this way, I'm a little concerned about it.
No, I completely understand. Maybe that person has a family member, right, who can help marshal things through. There was a piece of legislation that passed this past session, House Bill 1432, that goes into effect on January 1 of 2027, that says there can be no prior authorization required for the initial evaluation and first 6 outpatient visits. So that's where the legislature has stepped in and said, wait a minute, we got to cut back on prior auth for mental health services. And another example of sort of the legislature's acknowledgement of that is this office back in 2022 proposed that the legislature pass a law that says that a behavioral health crisis service, so mobile crisis response, crisis stabilization, evaluation, and treatment, be treated exactly like an emergency room visit. So it doesn't matter whether it's in network or out of network. There's no prior authorization. That claim has to be paid and the consumer can't be balance billed. So that was, and we're like, you cannot ask somebody who's going through a behavioral health crisis to deal with whether the mobile crisis response team who came out to respond to them is something that they should be balance billed for, or they should be told, sorry, you didn't get prior authorization. So when we have worked with the legislature on these issues, as the commissioner said, very sympathetic, and we've been able to get some pretty consequential bills passed on access to behavioral health services.
And Billy, I think this is a great time to remind the membership that the commissioner's door is always open. She meets with industry partners all session long. The door is always open. She's made herself fully accessible to answering questions, to being partners in this. And I think that that's a different approach than we've seen in previous years. So I will say it's been a great opportunity to have more dialogue with the Office of Understanding how the practitioners have a role to play in this, making sure that the membership understands that we're here for them as well. So if folks have questions or they have a patient in crisis and they don't know what to do, if they call me, I have great access to the commissioner, to Jane and others, to help answer some questions or alleviate barriers in that need. So if the membership feels like they need to make a call on behalf of a patient, but they don't know what to do, we're going to have all these new tools on the website for everyone. But also, I'm here to help everyone. The commissioner has said no wrong door. And I think helping folks understand that, we have a partnership in this new administration that is much different than we've seen before.
Yeah, absolutely. And I really appreciate, y'all kind of giving us a sense for how we can work with your office, right? Especially when we're working with clients that are dealing with denials and noticing those behavioral patterns with, insurance companies where parity is not being, where we can raise that to you and you can enforce the law is really helpful. And then you're kind of saying here on our end, where we have work to do, is working together as MFTs. You're kind of talking about, Jane, like banding together. And it's like, well, the Washington Association of Marriage and Family Therapy, that's kind of the idea, right? Is that we're a group of licensed marriage and family therapists that has a legislative advocate in Amber. And that's the work that we still have to do, obviously, to make sure that we're able to get, Z codes reimbursed and proper reimbursement rates for our providers across the state and in our membership.
Absolutely. And I just want to take this moment. I know we're close to our time, but really just want to thank the commissioner for joining us on the podcast today. Our membership is going to benefit from this greatly, Commissioner. Again, I can't stress how amazing the transparency has been in the office with the new administration, the new leadership, and just really appreciate everyone's time today. And just stay tuned. We'll be revising the website and putting up some new links. We're going to make it as easy as we can for the membership to access the insurance commissioner's files and the guide documents and the templates. So everyone stay tuned. And I just really want to say thank you, Jane. Thank you, Commissioner. And thank you to our President, Billy, for hosting this today.
Yeah. And I just want to also say thank you so much for a great dialogue and also just a thoughtfulness and intentionality that I'm hearing, like going into your office on reaching out and having clinical providers to consult with and the behavioral health attorney that you mentioned, that it it does feel like supportive just to know there's thoughtfulness in the work that we're doing and that we have a partner that actually cares and is interested in the overall goal. So thank you so much for the dialogue.
Well, thank you for the opportunity. And we know we still have a lot of work ahead of us, but we want to keep the lines of communication open. As Amber talked about, I have an open door policy, and we look forward to partnering with you. And in addition to your complaints, if you have any solutions to issues as well, we like to hear those too. So especially when it comes to maybe simplifying the appeals process, or prior authorization issues, things like that, we love to hear solutions in addition to wanting to know what the problems are. So thank you again. Really appreciate the time.